Moving on, let's discuss Chapter 3 Pharmacokinetics and Pharmacodynamics. Through the phases of drug administration, it begins with pharmacokinetics, and this involves the drug's movement through the body and what the body does to the drug to metabolize that drug. Processes including things like absorption, distribution, metabolism, and excretion. On the other hand, pharmacodynamics is a term that refers to what the drug actually does to the body, involving receptor binding, post receptor effects, chemical reactions, and could be everything from biologic or physiologic responses. Drug absorption refers to the drug's movement into the bloodstream after administration. It could also things like dissolution, combining small drug particles with liquid to form a solution, or disintegration, the breakdown of an oral drug form into small particles. And all of these would affect how that drug is absorbed and brought into the body to be distributed for bioavailability. There are many different methods for drug absorption, beginning with passive transport. This is diffusion. And passive transport, again, is the movement of particles from an area of high concentration to an area of low concentration. On the other hand, we could also have active transport, and this requires a carrier. The carrier and energy to move the drug against the concentration gradient so that it is actually moving that drug where we need it, regardless of the concentration on both sides of that cell wall. We could also have penocytosis. In this case, the cell carries the drug across the membrane by engulfing the drug particles. There are a wide range of factors that could be affecting absorption, everything from blood flow, pain, stress, to the pH within the internal environment. It could also be affected by things like exercise, hunger, fasting, the food's fat content, temperature, electrolytes within that food, such as calcium that could be binding to the medication, and of course also the route of administration. When dealing with drug movement from the GI tract to the liver, this is primarily accomplished via the portal vein, and we also may see what's called the first pass effect. And in this case, the metabolism within the liver actually changes the molecular structure of that drug. And this also plays a major role in the bioavailability as the drug is then spread around the body. This bioavailability can be affected by everything from the drug form, the route of administration, the gastric mucosa and motility, the administration with food and other drugs, and of course, that first pass effect and the changes in the liver metabolism. Drug distribution is going to deal with the movement of the drug from circulation to our targeted body tissues. And it can be influenced by everything from protein binding, free drugs, the blood brain barrier, and the drug's ability to attach to the specific receptors we're targeting. Biotransformation, that is that drug's metabolism and how the body changes and alters that drug. The body chemically changes that drug into a form that it can secrete. The liver's the primary site of metabolism, though it also can hear terms such as half life, such as how long it takes for that drug to be broken down from its initially administered form down to half. And steady state, a patient's loading dose to get them up to a therapeutic level. These are all things that we have to think about when administering a drug. Drug excretion, or the elimination of drugs from the body, can occur in many different areas. The kidneys being the primary site where drugs are excreted with the urine. But this can also come from the liver in the form of bile excretion, lungs, saliva, sweat, and even breast milk. As we discussed in the beginning, pharmacodynamics. This is the study of the way drugs affect the body. And it can have our primary effect, which is the desirable response, the response that we're intending. It can also have a secondary effect. Could be desirable or undesirable. The dose response relationship is the body's physiologic response to changes in drug concentration at the site of action, affected by things like potency, which is the amount of drug needed to elicit a specific physiologic response. It can also have maximal efficacy, which is the point at which increasing a drug's dosage no longer increases the desired therapeutic response. We can also see things like the therapeutic index, which is the relationship between therapeutic dose and toxic dose, and also the therapeutic range, which is the range of doses that produce that therapeutic response. Pharmacodynamics would also deal with things like onset, being the time it takes for a drug to reach its minimum effective concentration. We could also see things like our peak, which is our highest concentration in the blood, as well as the duration, which is the length of time the drug exerts a therapeutic effect. When discussing therapeutic drug monitoring, the drug concentration is determined by measuring peak and trough drug levels. This is especially important in things like antibiotics. During the peak drug level, this is the highest plasma concentration of drug at a specific time. And the trough drug level, this is the lowest plasma concentration of a drug. You'll also see a lot of questions like this within your ATI and NCLEX, such as what is the best time to draw your peak and trough levels? Obviously, our peak level is going to be right after we've given that antibiotic, whereas the trough level, we want that to be at our lowest level. So we want to draw that level right before we give our next dose. We discussed receptors earlier. In receptor theory, the drug acts by binding to specific receptors within the body. They may activate a receptor by producing a response, or they may inactivate a receptor by blocking a response, such as the case of beta blockers, the cardiac medication we're going to discuss a lot if you haven't already know about it. And these receptors are found on the cell surface membrane, or can be what's found within the cell itself. There are four receptor families: the cell membrane embedded enzymes, the ligand gated ion channels, G protein coupled receptor systems, or transcription factors. Another aspect of pharmacodynamics are things like agonists, which activate receptors and produce desired responses. They could also be partial agonists that elicit only moderate activity when binding to receptors and work to prevent receptor activation by other drugs. They could also be antagonists, which prevent receptor activation and block any response from those receptors. There could be different selectivities. In the case of nonspecific drug effects, these affect multiple receptor sites. Or in the case of non-selective drug effects, these affect multiple receptors. An example here in our diagram would be beta blockers again. On our left, we have selective beta 1 receptor blockers, such as metoprolol, atenolol. And then on the right, we have the non selective beta blockers, such as carvedilol or labetalol. The mechanisms of drug action could be everything from stimulation, depression, irritation, replacement, cytotoxic action, antimicrobial action, or modification of the immune status. We discussed secondary drug effects earlier, such as the term you may be more comfortable with, side effects. And this is one of the primary reasons patients stop taking prescribed medication. A medication will have that desired effect, but it may also have some undesirable side effects. Not to be confused with an adverse reaction. This is an unintentional, unexpected reaction. Could be mild to severe of undesirable effects that we did not expect. Also, things like drug toxicity, which means a drug level far exceeds that therapeutic range. Pharmacodynamics could also be affected by things like the patient's tolerance for that drug. Tolerance meaning a decreased responsiveness to the drug over the course of therapy, in which case the patient requires higher and higher doses to achieve the same therapeutic response they initially got when they first began the medication. You can also see things like tachyphylaxis, which is an acute, rapid decrease in the response to a drug. Also, the very feral phenomenon of the placebo effect, in which case a drug response is not attributed to the drug's chemical makeup. Drug interactions are another very real phenomenon, especially when you start talking about patients that are on a large, wide array of medications. This is especially true in the elderly as well. And are seeing many different specialists. We got a lot of different doctors writing prescriptions. And these patients' med lists can grow rapidly, very quickly. In the case of drug interactions, this is an altered, modified action or effect of a drug due to the interaction with another drug. It's not to be confused with drug incompatibility or adverse drug reasons. These can also come in two categories again, pharmacokinetic or pharmacodynamic. For pharmacokinetic interactions, these are changes occurring in the absorption, distribution, metabolism, and excretion of the drug. For absorption, with multiple drugs, the rate of absorption of one or both drugs can change. A drug can block, decrease, or increase the absorption of another drug as well. Coming back to distribution, in the case of metabolism, a drug can increase metabolism of another drug by stimulating liver enzymes. These could be enzyme inducers or enzyme inhibitors. It can also affect the excretion of another drug, where drugs can increase or decrease renal excretion. Drugs can also influence the excretion of other drugs. There may also be additive drug effects, which is the sum effect of two drugs working together. For synergistic drug effects and potentiation, this is the effects of two drugs and much greater than effects in either drug alone, meaning the usage of another drug greatly magnifies the effect of the first drug that the patient was taking. They may also see an antagonistic drug effect, where one drug reduces or blocks the effect of another drug that the patient's taking. In the case of drug nutrient interactions, food may increase, decrease, or delay drug response. For drug laboratory interactions, drugs may cause misinterpretation of test results. And in the case of drug induced photosensitivity, drug induced skin reactions could be caused by sunlight exposure. When using our clinical judgment related to pharmacokinetics and pharmacodynamics, it begins with a concept, which is a caring intervention, the clinical decision making, and safety. Us as nurses, we need to be assessing our patients carefully. Everything from recognizing those cues to determine the potential for drug interaction problems, identifying the patient's current drugs, making sure we have an accurate med reconciliation or med rec. Also, analyzing the cues to prioritize our hypothesis. Everything related to anxiety, the need for further health teaching, and these will all play a role in helping us generate solutions. Our clinical judgment will also tell us when we need to take action, such as advising the patient not to eat high fat foods before ingesting an enteric coated tablet. Monitor that therapeutic range of drugs that are more toxic or have narrow therapeutic ranges. Things like digoxin or lithium, where the patients will need regular levels checked. Also, when they should notify their healthcare provider of drugs ordered that have antagonistic effects. And finally, can never get away from evaluating those outcomes. For our first practice question, a patient has liver and kidney disease. He is given a medication with a half life of 30 hours. What is the expected duration of this medication? With this liver and kidney disease, is it expected to be increased, decreased, remain unchanged, or dissipate? And that answer is going to be A, increase. With the patient's liver and kidney disease, we would expect the half life time of that medication to increase, and meaning that it's going to take longer for that patient to metabolize and excrete that medication. When assessing older adults and those with renal dysfunction, the nurse would expect the creatinine clearance to be which of the following? Would that be A, substantially increased, B, slightly increased, C, decreased, or D, within the normal range? And that answer is going to be C, decreased. We're going to see this discussed a lot, both in this course as well as when we get into other courses, about the effects of aging on the body. And just like anything else, as those kidneys get older, they don't quite excrete. They're not collecting in toxins, they're not concentrating urine and excreting as effectively as they used to when they were younger. For question three, a patient sustained significant burns to the skin and is experiencing fluid shift associated with edema in the fluid overload phase. The nurse would anticipate that this will interfere most with which phase of pharmacodynamics? That'd be A, absorption, B, distribution, C, metabolism, or D, excretion. And that answer is going to be B, distribution, because in this case, the severe burns have caused a major fluid shift. For question four, which nursing actions would be most appropriate for ensuring patient safety with a medication that has a low therapeutic index? That be A, monitoring a patient's urine output, B, assessing vital signs hourly, C, maintaining strict isolation precautions, or D, monitoring serum peak and trough levels? And that answer is going to be D, monitoring those serum peak and trough levels. And for our last question, what is the primary site of metabolism for most drugs? Is that A, kidney, B, small intestine, C, liver, or D, brain? And that answer is going to be C, in the liver. Pharmacokinetics and pharmacodynamics is important because you are the nurse at the bedside. You are the nurse administering that drug. And you really need to have a deep understanding of not only what drug you're giving, but also what effects that drug is going to have on the body and what potential complications could occur depending on our patient. But anyway, that's all we got for this chapter. I'll see you in the next slides.